weakness since last 6 months. So patient was all right 3 years back. He was able to, he was doing regular walks around 10 kilometers and walking three floors with ease. After which he started with a bit dragging of leg while walking. So he observed that he used to walk 10 kilometers, then his walking little decreased few kilometers. At that time, he noticed that there was little dragging of the left leg, and but he was able to climb the stairs, and his walking was still continuous. Over the period of next 6 months, the dragging increased, and he also noticed that there was difficulty in climbing stairs and also getting up from the squatting position. Also, during the same time, he noticed that there was difficulty in insinuating the chappals with left foot, and also started with slippage of chappals unknowingly from the left foot. At that time, there was no history of back pain or hip pain radiating to legs, but there was a history of cramps in the legs. After 1 year, he also developed weakness in the right foot. Now he was not able to climb the stairs, and also climbing down the stairs was difficult, but was walking with little support of kathi at home. Also, during the same time, he developed severe cramps and spasms in the legs, which were painful and occurring multiple times a day. He also observed thinning of legs, and also had muscle twitching at the thigh and calf. Since last 1.5 years, he's started having falls where he used to triple and fall. So he started using walker to walk. And around the same time, he also observed that there was difficulty in holding cup of tea or glass of water with the left hand. He felt his grip is weak. And but he was able to comb his hair and raise the hand above the head. He started at the same time. He observed there is muscle twitching in the arms, and also, there were severe cramps in the hands, such that during the cramps there was involuntary flexion of the fingers, even with slightest of the activity, which was more in the left hand than in the right, and it used to occur multiple times a day. He also observed that during the same time there was thinning of the hands and even the arms. The hands were more than the arms, and left was more thin than the right hand. And he also felt muscle twitching in the abdomen and back. Since last 6 months, he has difficulty now in holding cup or glass of water with the right hand also, but he is able to lift his hand up above the head. And also now he has difficulty during the same time. He started difficulty in going to washroom also. Almost he is bedridden, but he can walk few steps till the bathroom with the help of a walker and a help. There is also difficulty in getting up from bed. He needs support to get up from the bed, but he can turn in bed with little difficulty. More of difficulties because of his cramps and pain, according to him, while turning, and due to which his sleep is also disturbed. Now, there is no history of stiffness in the limbs or trunk. There is no history of dysarthria, dysphagia, or difficulty in holding neck. Mild dyspnea after there is little dyspnea after coming back from the bathroom, but at rest there is no dyspnea. No paresthesia. No, he is able to feel the flow and hotness and coldness of water. There is no bowel or bladder complaints. No blurring of vision or facial asymmetry or sensory loss or hearing loss or change in voice. There is no history of forgetfulness, navigation difficulty, distractibility, or behavioral changes. There is no history of intake of Ayurvedic medications or toxin exposure, and there is no history of fever, no history of joint pain, rash, photosensitivity, or skin lesions. Past history. He's known case of hypertension since last 6 years. He's non-diabetic, and there are no thyroid complaints or no thyroid disorder. Personal history is vegetarian by diet. There is no addiction. Sleep is disturbed due to spasms, and bowel blood is normal. Family history: his aunt son died in his 50s, but the exact reason is not known. Summary: 66-year-old male presented with asymmetrical quadriparesis, lower limb more than upper limb and distal more than proximal, with fasciculations and severe muscle spasm, without bulbar weakness, without sensory or bowel bladder symptoms, without cranial nerve or cerebellar or cognitive impairment.
Can you go back to the first slide?
Yes, ma'am.
The next slide. Hmm. So this patient, you're telling that she started having difficulty. There was dragging of left leg while walking.
Yes, ma'am.
Yeah. What does that mean?
Uh,
And from that,
ma'am,
what can you decide? Like if there is a dragging of leg.
ma'am, it could be because of weakness or either foot drop or because of even stiffness also
Yeah.
could be there.
So dragging of legs is usually a UMN complaint, right?
Yes, ma'am.
Okay. Then next complaint was that the dragging increased further.
He told that dragging increased and there was difficulty in climbing also during that time.
So what does this mean? That difficulty climbing stairs or difficulty getting up from squatting position?
Proximal muscle weakness, ma'am.
Which muscle?
Uh, a hip flexion, this
No, for getting
iliopsoas
up from squatting position, which muscle is needed?
quadriceps and hamstrings, ma'am.
No, getting up from squatting position, which muscle is needed? It is an anti-gravity action, na?
So knee extension and
No,
hip
not in knee extension. You need a
hip
gluteus
extension.
maximus.
Yes,
Hip extension. You
hip
need hip
extension.
extension to get up from the squatting position.
Yes.
Okay, when you have to get up from the, when you have to climb stairs, which muscle is needed?
Then knee and
Again, it is hip
yeah,
extension and
hip
knee
extension.
flexion. So you need hip extension, that is gluteus maximus, and knee flexion, that is hamstrings, for climbing
Yes.
stairs. But getting up from squatting position, majorly one muscle, that is anti-gravity
Hamstring.
muscle, which is gluteus
Muscle,
maximus.
which is maximus. Yes, ma'am.
Okay. Yeah.
Yes,
Then
ma'am.
what happened? Then you also noticed that there was difficulty insinuating chappals with left foot. What does that mean?
Uh, maybe there is weakness in the dorsiflexion or the toes. So while
No,
wearing
slip.
the,
Suppose, and your next sentence is slipping of chappals unknowingly from left foot. Slipping of chappals can happen because of
sorry,
which
this
all
is
conditions?
this was knowingly, ma'am. This is a
Uh,
mistake. Sorry.
okay.
So it could be because of weakness in distal weakness, that is dorsiflexion, but and also sensory if it is unknowingly, that is because of proprioception loss.
So slipping of chappals can happen because of what all things?
Either there is weakness or he is not able to feel the chappals. So weakness.
Is that the only reason where there can be slipping of chappals? See, basically you have to differentiate between two things. Slipping of chappals with knowledge, slipping of chappals without knowledge.
Yes, ma'am.
Okay. So if there is a slipping of chappals without knowledge, usually it is sensory.
Sensory. Yes, ma'am.
Sensory could be either large fiber neuropathy or posterior column or even ganglionopathy. These three are the sensory structures in LMN.
Yes, ma'am.
And UMN is posterior column. So you can have three conditions where there can be slipping of chappals without knowledge. It could be because of large fiber sensory predominant neuropathy. It can be because of posterior column, or it can be because of ganglionopathy.
Yes,
Okay.
ma'am. Yes,
But
ma'am.
then slipping of chappals with knowledge can happen because of multiple things. UMN plus LMN.
Yes, ma'am.
In LMN, there can be anterior horn cell, there can be roots, there can be peripheral nerves, neuromuscular junction, and muscle. That
Hmm.
is LMN. So there will be slipping of chappals without with knowledge in these conditions. But then there will be a history that there is a difficulty of inserting the foot inside the chappal.
Yes,
Correct?
yes, ma'am.
Those who have this LMN slipping of slipping of chappals, they have
Hmm.
difficulty inserting the foot inside the chappal. So they will
Yes,
take
ma'am.
the support. You can further elaborate your history, telling that patient started
Hmm.
requiring support of a wall. He used to put the
Hmm.
chappal supporting the wall and then insert the chappal inside it, in the foot inside it.
Yes, ma'am.
Okay.
Yes,
But
ma'am.
in UMN also there can be slipping of chappals. That is pyramidal dysfunction and extrapyramidal involvement and even the cerebellum. So how do you differentiate
Huh.
these three?
Um, Ma'am, in LMN there will be grip weakness. In cerebellum there will be difficulty in approaching the chappals. The leg will go here and there before reaching the chappal. And UMN, ma'am, I'm not sure about UMN. How to
Cerebellum,
ask?
there will be swaying of legs. When they are
Huh.
approaching the chappal, there will be swaying of legs. In
Yes, ma'am.
pyramidal, what will happen?
They will reach the chappal, but sliding inside the chappal will be
No,
difficult.
but we
So,
have decided, we have already discussed that that can happen in LMN, that there is a difficulty insinuating the foot inside the chappal. That is majorly LMN problem. Then in UMN, what history you will get?
uh,
Yeah. So there will be leg stiffness, which you are telling history. Ki there is a dragging or sometimes there is a stiffness history in the legs. That is UMN. And
hmm.
even the extra pyramidal, they have other symptoms. From other symptoms only you can get to know. That is, there are tremor, there is dragging of legs or slowness of legs while walking.
Hmm.
Okay.
Yes, ma'am.
So from your history, as of now, I'm not very sure ki LMN has happened or not.
Yes,
Okay,
ma'am.
so there is a dragging of legs and there is a dragging of leg while walking, and there is difficulty inserting the foot also, and there is slipping of chappal also with knowledge.
Yes, ma'am.
Insinuating difficulty is there, so it could be additional element also in that same leg.
Yes, ma'am.
Okay,
Yes, ma'am.
but I need more history.
Yes, ma'am.
Hmm.
Mm. So, ma'am, after a year,
So at this
also
point of time, there was no sensory symptom in the left leg.
no, no, ma'am.
Hmm. Okay, okay.
After
Then
a year, yes, ma'am.
yeah, next point.
So after a year, he also started developing weakness in the right foot.
Hmm.
Now he was not able to climb the stairs, or even climbing down the stairs was difficult. And also, he started requiring a kathi to walk at home. And during the same time, he
Now he
also
developed
developed
right foot weakness. You said. Right leg
right.
weakness or foot weakness?
Both, ma'am. Initially, he said there was difficulty in the like he had stopped wearing chappals, but more he noticed his weakness in the foot first. But even afterwards, walking and climbing was difficult.
Same way that happened in the left leg, right leg also same way it
Yes,
happened.
yes, ma'am.
Okay. But now here there is a climbing down difficulty also. Which muscle is needed for climbing downstairs, going
What
downstairs?
quadriceps is required, ma'am.
Yes. So that means you are telling now the quadriceps also become weak, which of the right leg or left leg?
Both, ma'am. Because he was not very clear about it, but he said there was difficulty. But there was no, ma'am, giving away on standing, like
Buckling
uh,
of knees was not
buckling
happening.
of no, ma'am.
Okay. Okay. Then what happened next?
Uh, he started developing severe cramps in the legs, which were very painful, and they occurred multiple times a day. And also, he did, observed the thinning of legs, and more in the thighs, the thinning was there, he observed. And also, there was the muscle twitching present at the thigh and the calf. So, after this, the disease progressed, and in the last 1.5 years, he started having falls. He said he tripled and fall. Foot came in between, and then he used to fall. Even he had ankle fracture once. So then
So you
he
are
started.
telling that there are severe cramps and spasms in legs.
Yes, ma'am.
Okay, which occurs multiple times throughout the day.
Yes, ma'am.
What is the significance of cramps? How do we differentiate cramps, fasciculations, and spasms?
Um, Ma'am, cramps will be associated with um, muscle. We say there will be tightening of the muscle while during the cramps, and there will be mild flexion or extension of the limb also during if there is a severe
Can
cramp.
anybody
Um,
better explain the difference between cramps, fasciculations, and what did I say? Spasm? What is the major differentiations between these two? Hmm?
Fasciculations, ma'am, the will see as rippling, but the cramps will be more painful and
Yeah.
it will
So
be feel.
first most important difference is cramps are painful, fasciculations are not.
Yes,
Okay.
ma'am.
First important differentiation is cramps are painful, fasciculations are not. Cramps are involuntary muscle contraction,
Yes,
whereas
ma'am.
fasciculations are spontaneous muscle activity.
Yes, ma'am.
Cramps are not spontaneous muscle activity, they are muscle contractions which are painful.
Yes, ma'am.
Okay, but spontaneous activity, muscle activity, or spontaneous muscle twitching is fasciculations.
Yes, ma'am.
Okay, and fasciculations are briefer than cramps.
Hmm.
Okay,
Yes,
and
ma'am.
yeah, then in this, what else can be the difference when you do EMG?
Ma'am, uh, uh, EMGM fibs will be present, or even
Fasciculations will
fasciculations
be
will be
noticed on the
present.
EMG, na fasciculation
Yes, ma'am.
potentials.
Yes, yes.
Whereas if you do EMG for cramps, what do you see in cramps on EMG?
Sustained motor unit will be there because of the muscle contraction, contracting,
Ah,
muscle
so
is
it's a
contracting.
muscle
So,
activity. You will notice
yes,
muscle activity. Myopathic
yes, ma'am.
nail. It is a muscle motor
Muscle act.
units. They are
Yes, ma'am.
contracting motor units.
Huh?
Okay. Cramps or not? Who said cramps are not EMG silent? Huh? Contractures
Mm,
are EMG silent. Okay. If you do
mm.
an EMG of a contracture, it will be electrically silent. Okay.
Yes, ma'am.
Yeah. And then
Even during cramp,
hmm.
even during cramps, ma'am, there will be visible muscle contraction or posture,
Yeah, muscle
physical
knots or
change.
muscle becoming
Yes,
tight like that you can notice or even feel.
yes, ma'am.
Okay. And then you mentioned spasms. You cannot say same sentence cramps and spasms. What is the difference versus between cramps and spasms?
Spasm might not be associated with uh, this amount of knotting or muscle, mm, involuntary painful activity, ma'am. Such painful as cramps.
See, this spasm can be with or without pain. Okay.
Hmm. Hmm.
That is one important thing. Okay. Which is the condition where you see notice spasms most commonly? Based on which you diagnose a disease.
Ma'am,
Based
can
on which you diagnose a disease.
that is cramp fasciculation, not
No, no, no.
no, no,
No, no, no, no.
no, ma'am.
On EMG, use
Ah,
spasm also is a motor unit activity.
yes,
Okay,
ma'am.
it may or with may not be with the with pain, but spasm is needed to diagnose on EMG in which condition?
Facial spasm, ma'am.
No,
Hmm.
it is stiff
What
person
else?
syndrome.
Yes, ma'am.
Yeah. Okay, stiff person
Hmm.
में cramps you don't get, you get spasms.
Spasms, yes,
Okay,
ma'am.
so it may or may not be associated with pain. Okay, and it's a larger muscle contraction than the cramps.
Hmm. Okay, ma'am.
Okay.
Hmm.
And there can be stiffness associated with the muscle knots.
Yes, ma'am.
Okay, which may not be there in a cramp case.
Yes, ma'am.
Okay, and when you do some motor activity like stretching, etc., cramps get
Hmm.
relieved. The spasm may not get relieved.
Hmm. Yes, ma'am. Understood,
Okay.
ma'am.
Hmm.
Yes, ma'am.
So that is the difference between these two. Okay. So
He had
so
cramps,
this patient, so
spasms,
you say clearly, if you are telling that they were painful, they are cramps.
cramps. They were cramps,
Okay,
ma'am.
they are occurring
Yes,
multiple
ma'am.
times a day. So, in which all conditions do you get cramps?
Ma'am, calf resicuation syndrome, even myopathies and anterior disorders, we can get cramps. Even
Hmm.
LMN disorders like in MMN also we can get cramps. CIDP, if it is
The
long
most
standing,
common cause is a motor neuron disease.
motor neuron
Okay.
disease. Yes.
Then you can get it in some neuropathies also.
Hmm.
And even the radiculopathies.
Yes, ma'am.
Or see, the conditions which we commonly see cramps are motor neuron disease. Then there is something called as cramp fasciculation syndrome.
Hmm.
Okay. And even this neuromyotonia cases, you can get cramps.
Peripheral nerve
Along with
hyperexcitability.
neuromyotonia, there can be cramps also. Okay.
Yes, ma'am.
Then even the hypocalcemia, etc. conditions also you can get cramps.
Yes, ma'am.
And some metabolic causes like hypothyroidism. Okay.
Yes, ma'am.
Yeah. So this
Uh,
patient started having cramps. And of course, the
cramps and
non-neurological condition is dehydration, electrolyte imbalance, etc.
hmm. Yes, ma'am.
But then patient also noticed thinning of legs.
Yes, the more
Which areas
ye-
of legs?
thigh as well as his uh, calves.
Thigh means which muscle? Is it
Our
the
anterior
anterior
portion,
aspect of
anterior,
thigh, or is it the medial aspect of thigh, or lateral aspect of thigh?
more in the anterior and medial aspect. He
So which
saw
muscles that
changes.
means? Quadriceps
Quadriceps,
and adductors.
adductors. Yes, ma'am.
Yeah. Okay. Then he also noticed twitching in thighs and calf.
Yes, ma'am.
What do you mean by that twitching? Was it associated with pain or not?
No, it was not associated with pain, ma'am.
And it was a very brief movement or it lasted for a long period of time?
No, brief but occurring multiple
Multiple
times.
times. Okay. Was it happening at rest or when he used to do some movement with that part of the leg, then it used to
No,
happen?
even at rest,
So you have
it
to
was.
mention all of this.
Yes, yes, ma'am.
Why did I ask for this?
Mm.
Hmm? If the
Uh,
twitching is happening at rest versus if it is happening on movement of that body part.
because ma'am, even in healthy individual, if strenuous exercise is done, they can get fasciculations or benign, even to differentiate benign versus.
No, you see what so we'll come to that. But I asked ki resting versus on movement. If somebody is getting twitching which is so brief, usually and non-painful, usually first thought will be fasciculations. And also there is associated wasting. You have also already mentioned the same areas have thinning also.
Yes, ma'am.
Okay. So most likely they are fasciculations.
Yes, ma'am.
Okay. But then why did I ask you if it is resting versus if it is on movement? So resting fasciculations usually happen with the anterior hornsel disease. Okay.
Okay.
If you are moving a leg part or a body part and then you are getting some twitching or fasciculations and not happening much at rest, it still could be a possibility that roots are affected.
Okay. Ma'am.
Okay.
Okay, ma'am.
Florid fasciculations at rest are usually anterior hornsel.
Okay, ma'am.
If the movement on movement fasciculations are happening, usually they could be roots related.
Okay, ma'am.
Okay.
Hmm.
Hmm. So now what is the difference between the benign and actually pathological fasciculations?
Pathological fasciculation will be associated with weakness. Benign won't be associated with weakness.
Hmm.
And progression of benign won't have any progression, but the pathological will have further progression.
Hmm.
Uh, no treatment is required for benign, but And
No, but before that, something important is there, no? Just now we discussed that if there is a see, if there is a fasciculation and there is associated wasting and weakness, they are pathological.
mm,
Hmm?
yes, ma'am.
If they are
It
not
is.
associated with wasting and weakness, it is benign.
Mm,
Most important differentiating point is that. Second is progression, which you mentioned. That benign will be stable or sometimes they come and go fluctuating.
mm,
Okay. Whereas there is a continuous progression, usually it is pathological.
mm,
Hmm? Younger age group, again, it is benign. More could be benign. Older age groups could be pathological. Hmm?
yes, ma'am.
Then anything else? What about the sites of fasciculations?
Right. So, some tongue fasciculation is abnormal pathological fasciculation,
Young are
and we
abnormal, yeah.
then
So, for example,
even
eyelid
eyelid
fasciculations are
fasciculation,
happening or calf fasciculations are
cough.
happening. They are usually benign, and then benign tend to be very multifocal. Okay,
Hmm.
whereas or it can be like one day in this area, another day in other area. Okay, whereas in pathological fasciculation, usually they tend to happen at one place only multiple times.
Hmm.
They follow a particular anterior horn cell group pattern like that, segmental pattern. Okay.
Yes, ma'am.
Yeah. So this patient started noticing there is a thinning also, and then there is a fasciculation also, and then there are cramps also. Okay.
Yes, ma'am.
Then
So, so he
so we have
started
to keep it in
falling.
mind that this could be anterior horn cell
Yes, ma'am.
because the way it is associated with thinning, wasting also, and fasciculations also, and cramps also. But still, we have to keep the possibility that there could be roots, multiple roots, or radiculoneuropathy also. Neuromuscular junction or muscle is less likely.
Yes, ma'am.
Then,
So he started having difficulty in holding cup of tea and glass of water with left hand since last 1.5 years, and
hmm.
he felt that his grip is weak, and but he was able to comb his hair and raise hand above the head, and
Hmm. Which means
also
what from this your history? It means what?
the intrinsic muscles of hand are weak, but the proximal muscles
No,
are.
see,
Uh,
holding the larger objects in the hand, like for example, holding a glass of water.
hmm,
Okay, holding a glass of water requires long flexors. Okay, holding a cup of tea, it requires long flexors of the hand. Okay, so it is not intrinsic muscles, it is indicative of long flexors have become weak. Okay, for small muscles, small intrinsic muscles, what history will you ask?
is he able to
For example, if you
digest the
have,
food?
yeah,
So chapati, breaking the chapati,
yes,
is it?
breaking the chapatis. What else?
Mm, uh, picking up a coin or doing pinching,
Classically, what do we ask? Opening jar is again long flexors. Huh?
opening the
See, breaking chapatis, you require which muscle?
abduction and adduction, interossei and lumbricals will need.
So, breaking chapatis, usually you have to break chapatis. That means you have to adduct your thumb, right?
Huh.
And you need to bring all the fingers together. Okay.
Hmm.
So, introssei are needed. But along with
Hmm.
that, adductor polysis is needed.
Hmm.
Okay, so
Yes, ma'am.
that is one history that you can ask breaking chapatis. Then you can ask clipping of nails. Many times you get that history that they start having difficulty clipping their own nails. That is
Hmm.
also adductor polysis. Okay.
Okay. Yes,
Then
ma'am.
they start having difficulty buttoning, unbuttoning. That is also like small introshay weakness.
Hmm.
Okay. Then also they start having difficulty making food bolus. Again, it requires introshay and lumbricals and adductor and adductor polysis. Okay. So small muscles ke liye you have to like intrinsic muscle. You have to ask all these complaints. Okay.
Yes, ma'am.
Yeah. Holding glass of water is long flexors.
Yes, ma'am.
Okay.
So buttoning and
Yeah.
unbuttoning was
Buttoning,
also,
unbuttoning is small muscles. You can ask that history.
that was
Okay. Holding a
difficult.
pen is also long flexors and a little bit of adductor polysis.
Yes,
Adductor and
ma'am.
opponent's polysis is needed in that. Hmm?
Yes, ma'am.
Hmm. So
So
I'm not
along,
sure from your history whether he has this small muscle weakness, but he has definitely long flexor weakness. Okay.
and
Then
buttoning was also difficult. He
okay.
said, and during the same time, he also started having muscle twitchings in the arms and also cramps in the hand with involuntary flexion of the fingers during the cramps with slightest of the activity, more in the left hand. And it also occurred multiple times a day. And
Hmm.
during the same time, he also observed thinning of his hands and arms also, but hands were more thinner than arms. And also, after a few months, he started feeling abdominal twitching and even at the back.
Hmm. Okay. Then
And since last 6 months, so he has difficulty in holding a cup of water from the right hand. Also, buttoning and unbuttoning is difficult. And but he was able to wi- lift up his hand above, and also now he
see,
has
in that
difficulty in.
also, in arm or upper limb also, see, you started off with the distal weakness, that is difficulty buttoning, unbuttoning, then difficulty clipping of nails, difficulty breaking chapatis, all this for distal muscle weakness is there. Then you can ask whether they can mix the bolus of food, etc. That is also for small muscles. Then you can ask for the semi-distal muscles. Okay, so if they are able to lift the objects till the arm level.
Hmm.
Okay, so that if that is also becoming weak means semi-distal muscles are also becoming weak, like biceps.
Okay, ma'am.
Okay, so that you are telling that there is a wasting of arm muscles, but you have not told any weakness is there in that distribution. You are just telling that there is a no difficulty lifting the objects overhead, which means deltoid onwards. Okay, so those seems to be okay, but there is
He
a
said it
thinning
okay.
of the arms that he has noticed. Arms and
Yes.
forearms. Okay, so if that is there, then you have to ask for that history also, na? So if he is able to lift the object till his arm level, or a bucket of water till his arm level, then we can say that even the biceps, the power is okay in the biceps also. Okay, but there is a
Yes.
wasting more noticed in that area.
Actually, ma'am, he didn't he didn't use any of this trend because of this digital weakness, but he was using his walker to walk. So by lifting the walker, he was able to lift till
Lift
the
it.
little.
Okay. So that means there was a wasting, but not much weakness that had come up. Or we have to ask. See, most many times what happens, the patients they used to lift lot of heavy objects before, and then they start reducing the kgs. Okay, so you can
Huh.
say that patient was he used to be able to lift about 10 kgs or 15 kg objects previously. Now gradually he started reducing those weights. Okay, and then
Yes.
now he is able to do only 1 to 2 kgs like that. So that history is important. That will also indicate that weakness has come or not in those areas.
Okay.
Okay, then
There was there is also difficulty in getting up from the bed. He is needing support. And,
hmm.
turning his in bed is also difficult. But he is, according to him, he there are more cramps when he tries to move. So because of the pain and the cramps, the turning is difficult, and also his sleep is disturbed because of the pain.
Hmm.
And there is no history of stiffness in the limbs or trunk. There is no history of dysarthria, dysphagia, or difficulty in holding neck. Mild dyspnea is there after he comes back from the bathroom, but there is no dyspnea at rest. And there is no paresthesia, no, he's able to feel the floor and hotness and coldness of water. No
In your
bowel blood.
history of lower limb weakness, can you go
Yes,
back to the one slide?
yes.
In lower limb weakness, now you have to, here you have difficulty climbing stairs and all that you have described. But what is the current neurological status? Is he bound, bed bound state? Is he wheelchair bound state? Is he walking with walker? That is not mentioned.
Here, ma'am, I mentioned he's difficulty in walking till bathroom, almost bedridden, but
Okay.
only can walk few steps till bathroom with the help of
With
a
a
walker and
walker.
a help.
Okay.
Yes, ma'am.
Okay. Hmm.
So
Okay.
there is no blurring of vision, facial asymmetry or sensory loss in the face, hearing loss or change in voice, no forgetfulness, navigation difficulty, distractibility or behavioral changes, no history of any Ayurvedic medication toxin
What
exposure.
about breathlessness? You mentioned that.
But only at rest it was not there. But going to bathroom, those few steps while going and coming back, at that time for some time he was listening, but then at rest there was not there, and even in the supine position it
Is
was
he
not there.
able to sleep? Is he because of pain only he's not sleeping, or he feels a little breathlessness at night when he's lying
No,
down?
no, no, ma'am. I'm asked many times. He said no, I'm comfortable lying down,
Hmm.
but because of the pain, I'm not able to sleep.
Okay. Hmm.
जाग आ जाए.
Okay. No swallowing difficulty as well.
No, no, ma'am.
Okay. Okay. Then
Um, Past history. There is no history of, sorry, he's known hypertensive
take
since
a
6 years.
minute. Just go back to the slide. When you are asking for the history, first is negative history for localization, right? And then you have to ask for the negative history for etiology, and then negative history for complications. Hmm? So, in the negative history for localization, you said there is no history of stiffness or in limbs or trunk. Okay. Then there is no other cranial nerve involvement from your, there's no history of blurring of vision, facial asymmetry, sensory loss, hearing loss, change in voice, and all that. So that means there is no other cranial nerve involvement. There is no bowel bladder involvement. There is no imbalance while walking. Hmm? There is no imbalance of the limbs. Hmm? There is no cognition involvement. That is no history of forgetfulness or behavioral changes and cognitive difficulty or seizures. Okay, that you have to mention seizures also.
Okay.
Okay, and there is no slowness of activities. Okay, and there is no involuntary movements besides this twitching, because other
No.
involuntary movements also we expect, no? Okay, so
Uh,
that is not there. And then there is no history of repeated. Acha, now you have to come to the etiological history. Okay, so why did you ask for the joint pain, rash, and photosensitivity?
any autoimmune cause, but
Which autoimmune conditions can you get this type of motor involvement with fasciculations?
as such, it
So
is not
if you
there with
don't know,
me.
don't say. And even the fever part, I don't know. Like you have history of 1.5 year.
Hmm.
Okay, fever could be a complication history.
Hmm.
Even in stiff person, you don't get joint pain, rash, and photosensitivity, all that, na?
Hmm.
Seizures, I asked for two things. One is that in which condition of motor neuron for from your history, one first possibility goes to anterior horn cell. So from in which conditions of motor neuron you get seizures?
You get what, ma'am? Sorry.
Seizures.
Yeah, with seizures. I'm not sure, ma'am.
Hmm? Anybody? seizures, and motor neuron disease. One is this genetic seizures, genetic ALS. Okay. In that also C9orf72 you can get. Okay. But more I was inclining towards adult onset Tay Sachs.
Okay, ma'am.
Okay. Yeah.
And some genetic cause maybe,
Yeah.
but
So
he's
familial
66.
ALS
Hmm.
conditions you can get. Okay.
Okay.
So seizures you should ask. Parkinsonism you should ask. Any other involuntary movements like chorea, etc. you should ask.
Hmm.
Why Parkinsonism?
Again, ma'am, association with Parkinson ALS, FTD is there.
Yeah, Parkinson
Park,
dementia
Park,
complex is there.
yes,
Parkinson ALS dementia complex is there.
yes,
So that is why we need to ask that.
yes,
Okay. Okay. So so these two history that fever, at least you can justify fever that maybe because of bed bound state patient may develop fever, this that. But joint pain, rash, and photosensitivity skin lesions, you can't give any answer for that. Then you have to ask if there is any family history. You have mentioned it is not there. Correct.
no, no family history.
And repeated trauma history.
Repeated trauma, no, only
No, no history
during
of trauma.
trauma. Huh.
Hmm. Hmm. No history of weight loss.
Actually, ma'am, he said that because of the thinning, there was
No, thinning
is
is
that,
different.
but
Weight loss. Weight loss is there or not? That you have to ask. They must have checked his weight at some point of time, na?
uh,
Okay.
go ahead, ma'am.
This much you can ask for the negative part. Then move ahead. Go ahead.
Yes, so the past history, known he's known hypertensive since 6 years. He's non-diabetic, no known thyroid disorder. Personal history is vegetarian by diet, no addiction, sleep disturbed due to spasm. Bowel bladder is normal. His family history: aunt son died in 50s, but reason is not known. Uh, in summary, 66-year-old male presented with asymmetrical quadriparesis, lower limb more than upper limb, distal more than proximal, with wasting, with fasciculations and severe muscle cramps, without bulbar weakness,
In
without
this
sensation.
summary, you should mention 66-year-old male. Insidious onset and progression, you have to write no. So
Yes, ma'am.
insidious onset, gradually progressive or rapidly progressive?
Gradual progression.
Gradually progressive, asymmetrical, hmm?
Yes, ma'am.
Asymmetrical, pure motor.
I thought we have to say in this word, so I written without
Oh, you have
sensory.
to write that. So
Okay,
it
okay.
is what subacute so insidious onset, gradually progressive,
Yes,
asymmetrical, pure motor, LMN type more than UMN. Okay, lower limb more than upper limb, distal more than proximal, quadriparesis
yes, ma'am.
with fasciculations. You don't have to keep that spasm thing here. With fasciculations and cramps, like that you can say.
Okay, ma'am.
Hmm?
Okay, ma'am.
And you can say that without bulbar involvement, without respiratory involvement, and
Hmm.
without any cognitive or bowel bladder involvement. Cranial nerve, cerebellum, all that you don't put there.
Okay, ma'am.
Hmm? Cognition, bowel bladder, and bulbar. These three are the most important thing. Because then,
Yes, ma'am.
what is the answer? Why cerebellum you are asking?
No say relevance in that, but I thought
So don't put
everything we
like
have to
that.
write. Okay,
So
ma'am.
whatever is most relevant, you have to write there. Okay?
Okay, ma'am.
So now you tell what are your structural localization?
My first is, ma'am,
Somebody
element
said
plus
ska.
UMN
So which
is
ska? That's what you should know, na. If you want to utter something, then you should tell answer also. That cerebellum is there, and you are telling a motor neuron disease. Which condition you get cerebellar and motor neuron disease? Hmm?
No, ma'am, I don't. No, no,
Ah, no,
nothing.
SCA3, most common.
Yes.
SCA3 is there with ALS complex.
Mm-hmm.
Then you can get sign one in you can get it in sign one ataxia. Okay, 50% cases have motor neuron disease. Then you can get it in even spastic ataxia can be there in, for example, adrenoleukodystrophy. Even Tay-Sachs disease. Okay, because Tay-Sachs you should remember for as a cause of ALS, inherited ALS.
Okay, ma'am.
Mm. Okay,
Uh,
so you should ask for that. I mean,
okay,
you
ma'am.
should know differentials ki har ek, like whatever anterior horn cell, you should know the associated condition like Parkinson and ALS, uh, movement disorder like chorea, etc. with ALS. Can you
Mm.
tell which conditions you can get chorea and ALS?
Uh, I knew this. C9ORF again, ma'am.
Yes, C9 or F72. Then
Yeah.
very very important.
No, ma'am, I don't.
HD. HD is also being diagnosed as a gene for ALS now. Okay,
Okay, ma'am.
late onset HD. Mm.
Hmm.
Okay, so your localization, this is asymmetric, element, and pure motor. Motor much more with wasting and fasciculations, weakness, quadriparesis, which is proximodistal. Correct?
Yes, ma'am.
What is your localization?
Uh, I'm either mostly element, but I would also think element plus UMN, that is anterior horn cell
There is
or
no,
peripheral
no,
nerve.
no, 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 no. LMN plus UMN is ALS.
Yes, ma'am.
Correct? You want
Only
to
element.
structurally localize to UMN means pyramidal tract.
Hmm.
Hmm? At present, if you want to localize it to pyramidal tract also, there is no, in your history, there is nothing which is suggest your pyramidal tract except for
Yes,
that
ma'am.
history of dragging of legs.
Hmm.
I have to
Element
give
mostly, ma'am.
more features suggestive of UMN involvement is there.
At
Maybe
present,
there is
ma'am,
a
only element.
clonus. There should be a clonus history or some spasm, flexor spasm, extensor spasm ka history. That
Ma'am,
history is
I
not
had
there.
one question, ma'am. If like he is having cramps, he was having cramps, so how would we ask about flexor spasm in this case? I mean, how would we differentiate from the
No,
history?
see that one more point we wanted to discuss is that
Yes,
see
ma'am.
fasciculations they don't move the joint.
Okay.
Cramps they move the joint. Okay, and flexor spasm and extensor spasm they are involuntary flexion of legs and extensor involuntary extension of leg.
Okay.
Okay, so they are
Yes, ma'am.
different
Yes,
from
ma'am.
the cramps and this thing.
Yes.
Yeah, but in your history localization wise, at present it is more mainly
Element only.
anterior horn cell, LMN,
Element.
anterior horn cell. Second possibility could be roots, multiple roots.
Uh,
Okay, third possibility it is motor nerves.
hmm.
Can this be a muscle disease?
Less likely, but ma'am, it could be there because chronic asymmetrical is there, so it is against. But chronic
So tell me for and
in
against,
this is
for points for muscle and against point for muscle.
uh, chronic muscle like IBM in inclusion body myositis, there will be
No, no, no.
there are
I'm not
cramps
asking
plus
the disease. I'm asking
okay.
you
Cramps, ma'am,
between
cramps are
anti.
there
See,
plus
pure motor predominant symptoms you have. So LMS
huh,
structures which are pure motor predominant, anterior hornsel, motor roots, ventral
roots,
roots,
no,
then
motor nerve
motor nerves,
and
neuromuscular junction, and muscle.
muscle. Yes, ma'am.
Okay, neuromuscular junction is not there because it's a fluctuating. It's not a fluctuating disease.
Yes, ma'am.
Okay, so it is out. Is it
Hmm.
a muscle disease? What is the for and against point for muscle disease?
Pure motor one is for
For
the chronic along with muscle cramps. Muscle cramps are known in muscle diseases.
which muscle
Uh,
diseases have muscle cramps?
muscle spasm and cramps are then in polymyosite, but it won't be so chronic. Mm. Usually not, ma'am. But
Ah,
spasm.
so even the spasms can happen, but the cramps don't
Mm.
happen so much in the muscle diseases.
Yes, ma'am.
Okay, spasms can happen, and there can be painful muscle disease, especially the storage disorders or exercise intolerance cases where there can be painful cramps in metabolic myopathies, etc.
Mm.
Okay,
Yes.
but this is so against lot of factors are there. What are against factor for muscle disease?
It is asymmetrical plus
Hmm.
fasciculations are there.
Hmm.
Plus so much of muscle cramps are there. So it is going against muscle disease.
Also, in muscle diseases, weakness is much more than the wasting complaint.
Wasting. Yes, ma'am.
In this patient, there is a lot of history of wasting and fasciculations than the weakness.
Hmm.
Okay, so these points are against muscle disease.
Hmm.
So asymmetricity is also against muscle. Muscle
Yes,
disease
ma'am.
is symmetrically proximal predominant. That is
Hmm.
also another point. In this patient, asymmetricity, proximal plus distal. In some
Hmm.
places, distal more than proximal.
Hmm.
Okay, wasting more than weakness,
Yes, ma'am.
fasciculations and cramps. All of these
Hmm.
points more towards the anterior horn cells.
And also. Yes, ma'am.
And they are the against points for the muscle.
Yes, ma'am.
Why it's not roots, multiple roots?
Again, so much of cramps won't be there. And
No,
ma'am,
no, no, no.
so
Radicular pain.
radicular, yes, ma'am.
Yeah,
Back pain and
there
my
is no
radicular pain is
radicular
not
pain
there.
history,
Yes, ma'am.
and there is no pure motor roots and little sensory symptoms, nothing is there.
Nothing is there. Yes,
Of
ma'am.
course, motor CIDPs are there. Okay,
Hmm.
so you say that it cannot be 100% ruled out.
Okay, ma'am.
Okay, unless you examine and you do an EMG, you cannot 100% rule out roots.
Yes,
Even
ma'am.
when you give EMG reports, you cannot, the localization is site of localization on EMG is anterior horn cell or multiple roots.
Yes, ma'am.
Understand?
Yes, ma'am.
Why it's not peripheral nerves? And if peripheral, which peripheral nerves condition can come like this?
Asymmetrical, ma'am, I can only think of a multifocal motor neuropathy, but it is more like peripheral nerve distribution than
So, what are the points against for multifocal motor neuropathy in this case?
um, it is more of myotomal distribution than this peripheral nerve distribution
So,
because
multifocal motor neuropathy tends to be in the distribution of that particular nerve.
hmm,
Weakness tends to be in the distribution of that particular nerve. That is one point. Then,
fasciculations and cramps again
so
they are more
fasciculation,
in
even the wasting part, wasting
wasting
and
is not there.
fasciculations are more a feature of anterior horn cells rather than multifocal
Multi,
motor neuropathy.
yes,
Okay,
ma'am.
multifocal motor neuropathy tend to have a preserved bulk of the muscles.
Yes, ma'am. Even
Okay,
in 3 years history, if it is not picked up, then
there can be, of course, there are odd cases in each thing, but still, that to
hmm,
grossly describe between the two, one thing is a
hmm,
wasting and fasciculations is odd against point for the MMNCB.
yes, ma'am.
Okay, a preserved bulk of muscle is a feature of MMNCB because there is a conduction block in that. It's
Yes,
not an
ma'am.
axonopathy.
Yes, ma'am.
Okay. Then, any other point? What happens to the distribution of weakness in MM and CB? We just
Upper limb
discussed
is
that
more.
there is an
Upper limb
upper
is
limb.
more
Yeah,
than,
upper limb.
and
Is it
there will be
flexor group
radial,
or extensor group?
radial. There will be wrist drop. So
Extensor group.
extensor group
Yeah,
will be.
there is a finger drop or the wrist drop. Okay,
Yes,
so
ma'am.
that is MMNCB. It is exactly opposite to the inclusion body myositis, where there is involvement of flexion group of muscles.
Flexion. Yes, ma'am.
Okay,
Yes, ma'am.
so these points are saying that this may not be MMNCB. Okay.
Yes, ma'am.
Huh. Then you mentioned one more differential, that is PMA.
Yes,
Why
ma'am.
do you think it is PMA?
Because, ma'am, symptoms are pointing towards element. Plus, ma'am, so chronic, 3 years history, and he is not having any bulbar involvement. So, I'm like, I'm more from the history.
So
I'm
that
more
is why
towards
if you try
PMA.
to get a history of UMN, your
Mm.
differentials narrows down further,
Yes,
isn't
ma'am.
it? And what kind of pattern do you get in PMA?
Mm.
Of
It is
course, it is
similar
sensory
to.
predominant as you mentioned, but what kind of pattern do you get in PMA?
It is slow progressive, and
Hmm. How slow?
after 4 years, they might get a UMN symptom, but
4 years? No,
still.
10 years they have mentioned, I think so. UMN
Okay.
features can come after 10 years. That's slow progressive.
Okay.
Hmm?
Yes,
And
ma'am.
where is the pattern of weakness more in PMA?
I mean, it is same as this.
It's again upper limbs. Upper limb
Okay.
distal. Yeah. More in the upper limb distal. Okay.
Okay.
Then
Hmm.
myopathy. Which myopathy you want to say? Inclusion body myositis?
Because of old age, but
Because
it
you
started
know,
with
first
foot
of all,
drop.
there is
It
no
could
so
not
much
be
of
there.
asymmetricity in a myopathy.
It could not be there.
Again,
Plus,
wasting more than weakness is against point for myopathy. If
hmm,
it is inclusion body, it is upper limb distal and lower limb proximal cordyceps
proximal.
involvement.
Yes, ma'am.
That is against this. You have
Okay.
also mentioned a nodopathy. Which nodopathy can come like this?
Actually, it is 3 years, but still subacute onset of
Which
in NF
nodopathies?
180, 186 distal asymmetrical distal weakness is there. So just kept a
But
possibility.
are those pure motor?
No, no, ma'am. Sensory ataxia could be there, but in NF 186 they have
All
mentioned
of
it
the
is likely.
nodopathies, they are majorly sensory predominant. Sensory motor, not just motor, or not even
Mm.
motor more than sensory. It is sensory motor.
Okay,
Like
ma'am.
in NF 155, you have sensory ataxia.
Sensory ataxia, yes, ma'am. In 186 they had
It
just
is sensory
mentioned.
motor. 186 is like
Mm.
a Lewis Sumner kind of. So it is distal, upper limb, lower limb, like that. Sensory motor.
Yes, ma'am.
Okay, so I don't think you should mention nodopathy as a differential here.
Okay, ma'am.
Hmm? You
Okay,
want to
ma'am.
say CIDP? You
Mm.
can say CIDP, but don't say nodopathy. You can say motor variant of CIDP.
Okay, ma'am.
Okay. Still for motor variant of CIDP, it is still odd to have so much of fasciculations and thinning and
Yes,
wasting.
ma'am. Yes, ma'am.
Okay. Now, when you have come to first possibility as anterior horn cell, what kind of
Yes.
anterior horn cell disease this is?
Again, ma'am, from the history, LMN onset, it is more favoring towards it. So one possibility we can keep of progressive muscular atrophy, or it could, from the examination, we can see if there is any UMN involvement,
Hmm.
and that is spinal onset. Uh, that is what, ma'am. The
But would you not like to rule out some structural causes?
Yes, I
Correctable
would
causes, not
uh,
not structural. Correctable causes you will not like to rule out.
yes, ma'am, I would like to rule out correctable
Like
causes.
what?
Roots from multiple root involvement. So spine, I would like to do. Then,
See, till now you don't have any bulbar symptoms. So why
no,
not cervical compression?
the spine, that is
So
spine.
then, if you don't have bulbar involvement, uh,
Hmm.
it is still three lower segments, no spinal segments. So why not
Yes, ma'am.
cervical cord compression?
Yes, ma'am. That's
You know,
possible.
do you not get when there is a severe compression, there is a
Hmm.
myelomalacia, and there is a
Hmm.
myelomalacia which is causing signals along the anterior horn cells. In
Yes,
cervical
ma'am.
compressive myelopathy, you can get anterior horn cell infarctions also, or anterior horn cell severe injury. Okay, you
Hmm.
can get those snake eye appearances and all in cervical myelopathy cases. Remember, so you can get
Yes, ma'am.
anterior horn cell ischemia in the severe
Yes.
cervical cord compression, and you get only anterior horn cell like presentation. Even in syrinx, you
Hmm.
can get pure motor type of syrinx. You may
Hmm.
not get much sensory symptoms. You may not get, but that is one against point for cervical, that you can say that there is no sensory or bowel bladder involvement. Because if at all it is anterior horn cell predominant involvement, you may have a syrinx, no, or some
Hmm.
cervical compression over there, and then you should get UMN below that, and you should get bowel bladder involvement, and you should get plus minus sensory involvement. So
Yes,
these
ma'am.
are against point for the
Cervical
cervical
mind.
compression.
Yes,
But
ma'am.
then you have to keep that as a possibility.
Yes.
That is one correctable cause that you should keep it in mind.
Yes, ma'am.
When you are telling a differential, you should tell that first because it is only three segments, not the bulbar involvement. At least from your history, it's not there.
Yes, ma'am.
Hmm? Which other
Yeah.
correctable condition? So your localization, structural localization goes to anterior horn cell versus multiple roots, and
Till the
your
perineum now, I would want to keep.
etiologies could be either it is a progressive disease like progressing to PMA or ALS, or it is we want to rule out a structural cause.
Structural.
Yes. Okay. Which is
Yes, ma'am.
cervical myelopathy, hmm?
Yes, ma'am.
Or some intramedullary lesion. Okay.
Yes, ma'am. Yes.
Okay. So examination part.
So, examination, patient was conscious, oriented to time, place, and person. Vitals are stable. No pallor cyanosis, clubbing, lymphadenopathy or pedal edema. No neurocutaneous markers, skin changes or xanthelasma. Spine is normal. High mental function. Patient is alert, cooperative. Rigid forward is 5. Tape normal. Back, backward is 5. Speech, memory, language is all normal.
See, in
And
higher mental function, that's what. So attention and MMSC fab, at least these many should be done in a short case.
yes, ma'am.
Attention, MMSC and fab, which takes 6 minutes each.
Yes,
Okay.
ma'am. Yes,
You
ma'am.
don't have to do the detailed this thing, the low bar assessment. Of course, unless it is some FTD ALS kind of case, then you might have to. But usually
Hmm.
they don't give that kind of case.
Yes, ma'am.
Okay. Uh, Here in this higher mental function, here you cannot say speech. You finish your higher mental function with low bar assessment and all, and then you go for the speech. Speech is normal in this case. MMSC and FAB score is also normal. There are no frontal lobe release signs.
No, ma'am.
Okay. Then
In cranial now, or affection was normal. Pupil bilateral equal reacting to light.
what do you
Vision
expect in
normal.
extraocular in ALS? Or what do you expect here in extraocular involvement?
Mm. ALS Parkinsonism complex or associated with any other thing. Only then, ma'am. Pure ALS one we
If you
have
get a
any.
gaze palsy, vertical gaze palsy, what will be the differentials? And you have some sort of ALS.
ALS with Parkinsonism, ma'am. Like
Hmm.
C9ORF
Hmm.
we can think of.
Hmm.
Then ma'am, HD again, like you said before.
Hmm. Hmm.
Uh, then
So there is one, there is condition of FTD, ALS. Huh?
hmm,
Which genetic condition that is, and which protein abnormality it would be?
Pronulin, ma'am, a part.
No, no, not progranulin.
That is some part. I am not able to
Is it
remember.
MAPT? Is it progranulin? Is it something else? FUS. Which condition
Uh,
has ALS more commonly along with Parkinson's? TSP.
FUS, ma'am.
Hmm? No, TDP,
FUS,
TAR
TDP
DNA binding
43.
protein.
Yes, yes, ma'am.
Always
TDP
remember
43.
this, huh? The ALS is a disease of TAR DNA binding protein maximally.
Yes,
After
ma'am.
that, FUS comes. Okay, so most common is
Uh,
TAR DNA binding. And you
yes, ma'am.
can get, in that pathology, you can get vertical gaze pulses also.
Yes, ma'am.
Okay, even Tay
Yes,
Sachs,
ma'am.
you can get vertical gaze pulses.
Hmm.
Okay, what about who saw somebody mentioned saccadic intrusion? Which condition of ALS you can get saccadic intrusions?
Again, HD.
Not HD. You just now I mentioned once cerebral ataxia with ALS like presentation. SCA3, no?
Yes, SCA3. Yes, ma'am.
Then there is one more you should look for is Darov sign. Why do you look for Darov sign? Especially if you don't have bulbar involvement, gag is normal, there is no tongue involvement, and only spinal onwards there is involvement. Then you should look for Darov sign. Why? What is Darov sign? It is to rule out CV junction anomalies, right?
Uh,
Hmm? It's a Darov.
Oculomotor.
Darov sign is a downbeating nystagmus in the um, down and out eye. Okay,
Yes, yes.
so it's a pure downward nystagmus, usually indicative of floccular involvement. Okay, and it is because of high CV junction anomalies basically,
Yes,
and they
ma'am.
can come like this. They have wasting in the upper limbs, spasticity in the lower limbs, plus minus sensory, little bit of tongue wasting also can come if there is a involvement of syringomyelia and syringobulbia. Okay,
Yes, ma'am.
in extraocular you should definitely look for this. Okay,
Hmm.
especially if a younger patient is there.
Okay, ma'am.
Then
His
next,
gag was normal, ma'am, and tongue also there were no fasciculations or atrophy.
how did you check for gag? And you should mention gag and palatal reflex both.
It was
What is
also
the
normal.
difference between these two?
Gag will check will ask to open the mouth, depress the tongue, and then strike at the posterior pharyngeal wall. And palate will ask to say ah, and then
Hmm.
loop
So
the
as
palatal
soon as
region.
you start examining, you ask the patient to say ah, and you check for the palatal arches and the uvula. Palatal
Yes,
arches should be both at equal level and uvula should be central. That is a, and you ask them to say ah. So the movement of the palate also should be good. Uvula should be central. That is palatal reflex. And gag reflex is with the help of swab sticks. Okay, you are touching the palatal arches and then you are going behind that and touching the posterior pharyngeal wall. That is a gag reflex.
yes,
Okay,
ma'am. Hmm.
and yeah, so if you get an absent gag reflex, what do you mean by that?
Bulbar involvement is also there, ma'am. Element bulbar.
Hmm.
So
Does
most
it mean
not
by that? I mean, you are not getting any tongue wasting. You are not getting any tongue fasciculations. You just have absent gag.
pseudo bulbar, ma'am. But then
Pseudobulbar should
it
be
won't be over
brisk
there.
gag, no?
Brisk egg, yes, ma'am. Only that part.
See, if in the
No.
examination you have not noticed much anything in the bulbar area,
Hmm.
still to have an absent gag, it still could be like normal. 30% of people have normal gag, absent gag.
Okay. Okay,
Okay,
ma'am.
So unless it is associated with abnormal depressed arches, or you have tongue wasting or some tongue fasciculations, then it becomes very significant. Okay.
Hmm.
Then
Yes.
next.
Motor examination. On inspection, patient had muscle wasting present in bilateral arms, thigh, shin, or dorsum of the hand, and also the thinner more than hypothenor eminence, left hand more than right hand. And there was fasciculations present at the arm and
So
thigh,
why does the
even above,
clawing happen?
because long flexors and lumbricals are weak. So
Hmm?
lumbrical is weak.
No,
There
no,
will be
no. That's not that. You know the answer, but you're not able to tell properly. Why does somebody develop a claw hand?
extensor is nahi main, ulnar weakness because of the
If
ulnar.
somebody asks this,
Hmm.
you should have an answer ready because this is a very commonly asked question.
Yes, ma'am.
Okay. So there is a discrepancy between the power of the small muscles of the hand as compared to the
Mhm.
long flexors. Okay, so if you have
Yeah.
weakness much of the small muscles of the hand, like thenar or hypothenar muscles or introshae, but you have
Hmm.
long flexors are better than intrinsic these muscles. Okay, so then that will suppose long flexor digitorum longus or flexor digitorum profundus, they will start overacting, na? So that will give
Hmm.
rise to flexion of the fingers
Hmm.
because your intrinsic muscles are not acting; they are weak. Okay,
Yes,
so
ma'am.
there is this discrepancy between the long flexors and intrinsic muscles. Okay, so that is giving rise to clawing of the hand.
Yes, ma'am.
Okay, then
On palpation, the muscles are soft and flabby. And measurement, uh, there was little difference in the measurement of the right and left. Uh,
this is not is this a significant difference? How much should be
not
the
much, ma'am.
significant difference? Yeah, 2 centimeters. More than 2 centimeter would become a significant difference. And you know where to take the different the measurements, no?
Yes, ma'am.
Where?
In the legs, will take from the tibial tuberosity 10 centimeters below and above, from patella to 18 centimeters above the patella. And in the arm, we will take midpoint of olecranon process and the acromion process. Mid of that, will take the this
No, 10
measurement.
centimeters. No, 10 centimeter above and below
Hmm.
from the olecranon process.
Some, huh.
Hmm?
Yes, ma'am.
Mm. Okay, and then okay, in the inspection only you have written the fasciculations and which arm, thighs, abdominal fascia. What about the legs, calves,
There is
and
thigh
back
have written.
muscles? Abdominal you have written already. Okay,
Uh,
tick. Then next part.
these are his
Yeah, so
pictures,
this
ma'am.
patient has the clawing of the fingers of his left hand. Okay, so what is a split sign?
Ma'am, thinner
This
eminence
is
is
a
more
clawing of which finger?
little finger.
So it's a more of ulnar claw.
Yes, ma'am.
What is
Ulnar.
a complete claw? Ulnar
Both
plus
median and
median. Yeah.
median eminence.
Okay. So in that hand, in the left hand, it's more of hypothenar involvement. But in the right hand, we
Thinner.
can notice that there is a lot of wasting of the APP, abductor pollicis brevis.
Hmm.
Okay. So what
Yes,
is
ma'am.
a split hand?
Thinner more than hypothinner ma'am.
Basically, it's not thinner more than hypothenar. We call it as radial group of muscles. Radial group of muscles of hand. That is thinner, and even which muscle? FDI. These are
FDI,
radial
yes.
group of muscles.
Yes.
Okay. Thinner
Hmm.
group of muscles and FDI. That becomes the radial group of muscles. They are more
Hmm.
wasted than the
Hmm.
ulnar group of muscles. That
Hmm.
becomes a split hand. And reverse split hand.
Ulnar more than radial.
Okay. But then in that also you should know C8 more than T1.
Okay.
Which is what is C8 more than T1?
Hmm. Not sure.
The C8 and T1 ratio they calculate, no? In Hirayama. What is that? Anyone? Hmm? Which is a C8 innervated muscle. We do the CMAP of that muscle and we check the CMAP of T1 muscle and then we calculate the ratio.
Abductor pollicis brevis and digiti minimum.
Yes, very good. So C8 is abductor digiti minimi and T1 is abductor pollicis brevis. So
Hmm.
in Hirayama it is C8 wasting more than T1.
Hmm.
Okay.
Yes, ma'am.
So the normal ratio is, it is, how much is the ratio normally? C8 T1 ratio. This is a CMAP ratio I'm talking about, C8 T1. Normally it is zero point 0.6 to 1.6.
Ah, 16.6.
Okay.
Okay, ma'am.
And
Yes,
in
ma'am.
Hirayama what happens?
There will be reverse splitting,
Yeah.
like an anomaly.
So it becomes less, no? In Hirayama, that ratio becomes less, no?
Ah,
Okay. Uh,
yes, ma'am.
So you should remember this CMAP ratio of C8 and T1. Huh?
Okay, ma'am.
I think it is ulnar upon median. So they calculate T1 upon this one. Sorry, C8 upon T1. Okay. And that should be normally zero point 0.6 to 1.6. And if it is less than zero point 0.6, it is seen in Hirayama.
Hmm.
Okay.
Okay, ma'am.
Hmm. Yeah. Then Then you know all those polymini myoclose signs is there. Polymini myoclonus sign.
I I forgot to. I have the picture. There is a video. Polyminium is there.
Yeah.
And these were the fasciculations.
So
Like
why are
this
they
is,
not myokimias or neuromyotonias? When you look at them, why is it not myokymia or neuromyotonia?
they are of
Why are
longer
you calling
duration.
them as fasciculations?
They are short-lived
They are
and
also, both are brief.
over a larger group of muscle, it will be there and come.
Hmm? Myokymia are very continuous rhyming, rhythming,
Mm.
undulating kind of movements, like bag of worms they call it, na?
हाँ, bag of worms.
Continuous
Yes, ma'am.
kind of, and bigger
Rippling
muscles they
like.
are involved. Bigger muscles are
Yes.
affected. Here it is a
हाँ.
small muscle fiber is twitching in fasciculations,
Hmm.
whereas in myokymia it's a involvement of entire muscle or bigger muscles are affected. Okay. And the it is very brief and jerky in fasciculations, whereas it is more worm like continuous undulating kind of movement in myokymia. Okay.
Yes, ma'am.
Yeah. And of course, painful also. Sometimes the myochymias can be associated with painful or some tremors also of the leg. Okay.
Hmm. Yes, ma'am.
Mm. So these look like they are fasciculation. They are seen in tongue also are there.
No, 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 ma'am. Tongue was normal. There was no fasciculation. And actually,
Okay.
these cramps were there while testing. So much of
Ah,
cramp was.
okay. Okay. It was painful.
Huh, ma'am.
Associated with pain
Very
was
pain.
there. Okay.
Pain and massaging. After massaging, it was
Okay.
getting.
Yeah. Okay.
There was hypotonia in all four limbs, and neck flexion extension was 5 by 5. There was truncal flexion weakness, like he needed support to get up from the supine
There
position.
is hypotonia in all four limbs.
Ma'am, there was hypotonia. There were no UMN sign in him.
No, no, no. But hypotonia.
Hypotonia was
Have a
dragging.
video of the patient having hypotonia.
Ma'am, no tone. I don't have the video.
Okay. Then
Uh, uh, Power. So shoulder abduction and elbow flexion extension were both 5 by 5. On the right side, wrist flexion extension was 5 by 5. Left it was 4 by 5. Finger flexion, right it was 5 by 5, and left it was 4 by 5. Extension, abduction and adduction on the right was 4 by 5, and left was finger extension was 3 by 5. Abduction was 2 by 2. Abduction and adduction was 2 by 5, and thumb abduction was 4 minus in right and 3 in left. Adduction was 4 in right and 3 in left, and flexion was 4 plus in right side, and FBP it was 4 plus, and on left it was 4 by 5. And lower limb flexion and extension both were weak. It was 3 by 5 flexion, and extension was 2 by 5 bilateral. Abduction was 4 by 5, and left it was 4 minus by 5. Adduction was good, 5 by 5. Um, Knee flexion
see,
was
I
four
don't
by
know,
five.
but normally when we present a case of LMN, okay, neuromuscular case, for example. So in that we tend to mention the power by muscles.
Okay, ma'am.
Okay, like for example, now here elbow flexion extension. So I will say biceps, triceps. Okay.
Okay, ma'am.
In here, I would mention that small muscles, I would mention like that. So I will mention thinner muscles. So in that abductor pollicis long, abductor pollicis brevis, I would say adductor pollicis, opponens pollicis. Like that, independent muscle I will
Okay.
write, and independent
Okay.
muscle power I'm going to write, because this is not
Okay.
the way to show a power difference. In UMN cases, you can show say that this is a power at the joint. So you can
Hmm.
mention the joint powers in UMN cases. But in LMN cases, you mention it by each muscle.
Okay, ma'am.
Okay.
Okay.
Now, for example, here thumb abduction, adduction, and flexion you have written. What happened
Hmm.
to the so this one
Opponents.
little finger? Digiti minimica power only you have not mentioned. The entire
Uh-huh.
case goes on this basically in the ALS case. You have to
Yes,
mention
ma'am.
that
Digital.
it has to
Yes,
go
ma'am.
by the small
Hmm.
muscles of hand is a different, complete different topic only. Okay,
Yes,
how
ma'am.
to examine the small muscles of hand, and you have to write like that. The each muscle you have to write and power of that muscle. You may not be
O-
able to say 3 by 5, 4 by 5 because it is very difficult in those muscles. But you can all at least say weaker or weak. Which one is weaker? Is
Okay,
it
ma'am.
APB which is weaker or ADM that is weaker?
Digiti minimi
So
is
that
weak.
that thing you have not mentioned. Even the
Hmm.
extensor group of fingers, EDC, extensor digitorum communis, extensor indicis, all that I want. Extensor pollicis longus.
Extensor policies longest was good, ma'am. 4 plus
No,
4
but
power
you
was.
in the power when you are mentioning, you have to
Yes, ma'am.
mention each muscle in the
Yes,
upper limb,
yes,
in
ma'am.
lower limb.
Yes, ma'am. I'll take care next time.
Yeah. Okay,
Mm.
whenever you are presenting an element, make sure of that. Huh? Even in
Yes,
the
yes,
muscle case also you have to mention each muscle power. Iliopsoas kitna hai, adductor kitna hai, abductor kitna hai. That will give us an idea about the differential weakness also. Gluteus
yes, ma'am.
maximus, gluteus maximus kitna hai, iliopsoas kitna hai. Is there a differential between them? Adductor
Mm.
kitna hai, abductor kitna hai. Is there a differential between them? Like that.
Okay, ma'am.
And in upper limb, see, whenever you are starting with the power charting in upper limbs, you always start with the scapular muscles. Hmm? In that,
Ah.
it will be deltoid upper fiber, middle fiber, lower fibers. In trapezius, it is deltoid. It is anterior, middle, and posterior. In trapezius, it is upper, middle, and lower fibers. Then rhomboides muscle, latissimus dorsi muscle, pectoralis group of muscles. Okay, serratus anterior group of muscles. Okay,
Mm.
all of this infraspinatus, supraspinatus group of muscle. These will become a scapular muscle group. Then comes your इसमें थोड़ा बहुत teres minor major. Somebody gets an sudden jerk of asking that. Then in
Mm.
semidistal group of muscle biceps, brachialis, and triceps. And in the lower part forearm, that is brachioradialis, supinator. Okay, and wrist
Mm.
extension and wrist flexion. That much you can mention, like EDC, extensor carpi radialis, longus, extensor indicis, those group of
Mm.
muscles. And then in the small muscle, that entire thing is different. Small muscle may you have to mention all muscles of hypothenar, all muscles of thenar, along with that interossei and lumbricals.
Mm.
Power of all these muscles. Okay.
Okay, ma'am. Yes, ma'am. I'll
Similarly,
take
in the
care, ma'am,
lower
next
limb,
time.
it is iliopsoas, gluteus maximus, adduction, adductor group of muscles, and gluteus medius minimus, quadriceps, hamstring, tibialis anterior, tibialis posterior, peroneus, longus brevis, and gastrosoleus. Okay.
Okay, ma'am.
Yeah. Then,
Shall I play the video, ma'am?
yeah. Yeah.
Actually, I don't have all the videos.
That's okay. That's okay. We can go ahead. Actually, it's difficult to see.
Mm.
Hmm.
So, ma'am, actually reflexes on the day one when he came to us in the OPD, all the reflexes, biceps, triceps, supinator, even the finger and knee jerk were 2 plus, and the ankle were bilateral absent. But after 5, 6 days, when I again examined yesterday only, so I felt triceps and supinator were 3 plus, rest all were 2 plus. Like biceps was 2 plus, knee also 2 plus, ankle was absent. So maybe it is progressing because few days back it was 2 plus. I checked 2 to 3 times. It was 2 plus only.
Abdominal reflex is preserved.
It was present now.
Hmm.
And
Okay.
plantar were down.
Hmm.
Sensory is intact, no cerebral signs. So
What are the
localization,
grades of tone?
um, um, 5, Ellsberg
What is
classification
the
is there.
huh? What is the what is the scale used to check for tone?
Ellsberg classification is
Hmm?
Ellsberg classification, ma'am.
Ellsberg? No, no, no,
Classification
no, no, no,
5.
no. What is Ashworth scale?
Ashworth's classification scale, ma'am.
Yeah.
Sorry.
So Ashworth scale, that is modified Ashworth scale, is used to check for to grade the tone. Okay, you should know
Uh,
all the grades of it: 0, 1, 2, 3, 4.
2, 3, 4, 5, ma'am.
Okay.
Yes. Yes, ma'am.
Yeah. And then can you tell me MRC classification?
Uh,
What is 0 for muscle power?
power, no power, 0. One is a flicker of movement. Two is again with elimination of gravity. Then three is, uh, sorry, two is with,
बराबर है
huh. And three is against gravity. Four is
हम्म.
a mild with mild resistance, and five is normal power.
So what is 3 minus 3 and 3 plus and 4 minus 4, 4 plus?
4 minus is with it's more subjective. 4 minus is little resistance if
No, so
he
you
is
have to
able to.
grade it with the fingers. See, 4
Okay.
minus is resistance against to one finger. 4 is resistance to two fingers. And 4 plus is resistance to three fingers.
Mm,
Okay. And what is
okay.
3 minus 3 and 3 plus?
Uh, that I don't know, ma'am.
Anybody?
मैडम 1 3 and 5 है.
Hmm?
1 3 and 5.
Okay. But we used to
Oh,
do one finger, we do two finger and three finger we do. And five is like all entire fist. I'll just find out that part. But then there is three also, three minus three and three. Three plus.
But full range we will see. So like against gravity, full range is possible. Then 3
Hmm.
exactly. I
So
know.
minus 3 is like there is against gravity action, but no full range of movement and not sustaining also. Then
Hmm.
3 is against gravity, full range of movement, but little sustaining, not much sustaining. Plus 3 is full range against gravity, full range of movement, also sustaining. Okay. And 4
Hmm.
minus is resistance to one finger.
Yes, ma'am.
Okay. Hmm. And you should know the Ashworth scale and what are the how is the gradation of Ashworth scale and even the reflexes gradations. You know the reflexes gradations.
Yes, ma'am.
Hmm. Tell.
So ma'am, not zero is absent. One is
Hmm.
one is diminution of reflex. Two plus is normal. 3 plus is exaggerated reflex, and 4 is a clonus.
Okay. Fine. Zero is nothing.
No,
One
huh.
is with Gendrasik if it is coming. As a normally it will be absent, but if you do a Gendrasik maneuver, it is present. That becomes one.
Hmm.
Okay. Okay. Then so in your case, there is no increased tone, but then you are telling that all reflexes are good, 2 plus.
Hmm.
Hmm? So your hand is wasted, but your supinator reflex is 2 plus. What about finger flexion reflex?
It was also 2 plus, ma'am.
So if the finger flexion reflex is there in the
Hmm.
presence of wasting of in the muscles,
Hmm.
then it becomes a significant finding. That means there
Yes,
is a
ma'am.
UMN.
Hmm.
There is a UMN or not?
Yes, ma'am.
So it doesn't have to have a brisk reflex or tone hypertonia to call it as a UMN involvement. If there is a
Hmm.
wasted segment but preserved reflexes also in that segment, then it becomes a significant finding as a UMN.
Hmm.
Okay?
Yes, ma'am.
Yeah. Plantars, you said flexor.
Huh.
Okay. So now after the end of all this examination finding, in your last slide,
I would like to keep this
go
motor neuron disease first,
show
ma'am.
your last slide.
Which one?
Last one. No, not this. Examination last. Next. 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 Hmm. So now what possibilities will you keep?
Anterior Hansel,
At 2
ma'am.
plus somebody has asked this question. At 2 plus reflex, can we tell UMN? Yes. If it is a wasted hand, suppose there is a wasting of hand, forearm also wasting is there, biceps also wasting is there, and you are getting a reflex in a wasted muscle, it's a UMN finding. You don't have to have 3 plus reflex or 4 plus reflex or increased tone or plantar extensor to call it as UMN. In a wasted segment, if you have a present reflex, it becomes significant as a UMN finding. Okay? Yeah.
Yes, ma'am.
Hmm. So in your case, the first possibility still goes for the kind of wasting and all anterior horn cell with asymmetricity. So much of asymmetricity is there.
Hmm.
It's split hand. Okay. Only
Yes,
thing
ma'am.
that is odd is we want much more UMN than what we are getting currently.
Yes, ma'am.
Okay. So still there is a possibility that it may progress because it
Yes,
is
ma'am.
still progressing,
Hmm.
isn't it?
Yes,
But
ma'am.
at this moment, what will you do further?
EMG we will go for electrodiagnostic study.
So you have done electrodiagnostic study.
Yes, ma'am.
Show.
So amplitudes were decreased in median and ulnar bilateral. Peroneal and tibial were absent. Sensory was normal, and reflex was absent. And here, this on EMG there was fasciculation on
If
tibialis
somebody
and
has normal sensory and absent motor, what does it mean?
pure motor.
Hmm?
Pure motor involvement is there, ma'am.
Yeah, but if somebody has absent sensory and yeah, so somebody has answered it. It is preganglionic pathology.
Hmm.
Okay, if there was
Yes.
sensory absent, then it would have been a postganglionic, means nerve.
Hmm.
Okay, if somebody has an present preserved sensory and absent CMAPs, the it is LMN only, but it is preganglionic. So it could be motor roots or anterior horn cells. So when
Yes,
you are
ma'am.
giving a report, it will be anterior horn cell versus roots. Hmm?
Yes, ma'am.
So in the EMG, you found these fasciculations.
Hmm.
Okay. Can you tell me what are giant F waves and in which condition you see them?
No, I don't know, ma'am.
Hmm? Anybody? Hello. Sorry.
Hello.
Yeah. So giant wave F waves are basically large F waves, high amplitude F waves. Okay. And they happen usually in a condition where there is ongoing denervation and renervation,
Hmm.
which is motor neuron disease.
Yes, ma'am.
Okay. So that is one finding you can find in the NCS. Hmm? Okay. Then, so from this, again, you are you confirming that this is a motor neuron disease?
Yes,
At
ma'am.
least
There
all
was
the
fifth
factors are pointing towards the, but still it is motor roots versus anterior
anterior
horn
horns.
cells. Anything else that will help differentiate now?
MRI spine we will do for
Yeah, so that we
structural
have ruled
cause.
out. Now you have
Hmm.
ruled out spine is normal, and you still
Hmm.
have a possibility whether it is a motor neuron or is it some motor CIDP. What will you do?
It will be having conduction block, ma'am. So no conduction block was there in this.
No,
delayed
because
response.
see, if it's a root, what conduction blocks you will see? Nothing. You may not see
Acha, wait,
anything.
yes, yes,
Yeah. So somebody said CSF. So correct. So
yes, yes,
CSF
yes.
will help
Mm.
albuminocytological dissociation, but sometimes
Mm.
even that may not be there. Then what will you do? How do you diagnose CISP? Yeah, somebody said MRI will show root thickening. If suppose that is also not there, CISP diagnosis you do by doing what? SSEP, correct. But motor conductions will not be picked up in the SSEP. Then
MSAP. Mm.
hmm?
Motor evoked potential.
Yes, very good. So MEP, that is cortical motor evoked
Mm.
potentials, you study. And if there is a increased latencies or prolonged latencies, then it will be indicative that there could be roots. Okay. But
Mm.
from the clinical point of view, if you are getting a present reflex in the wasted segment, it is a UMN.
Mm.
Okay. What is LS Coriel criteria?
It is for ALS, ma'am. In definitive ALS, there should be UMN plus LMN signs in at least three segments, either one bulbar plus two spinal or three spinal. Then probable two sides of UMN plus LMN, and UMN should be rostral to LMN, and uh, with and probable is possible is one UMN plus LMN or
So can okay, 1 minute. Can you tell me what all criteria were there diagnosed for were there for ALS?
glucose criteria,
Yes.
LS scorer, and Awaji criteria, ma'am.
Correct, correct. So, which is the what is the modification? Like, what has happened in the Gold Coast criteria compared to LS Corel criteria? What changes have happened?
There is uh, UMN plus LMN or LMN dysfunction is there at least two body regions they mention like
See,
um,
basically,
uh,
till now, clinical assessment happened. Approach of the case is important. How you have ruled out other localizations, that is important, because in the case, most of the time till here, if your viva goes well, then the questions will go further. Okay, about
mm,
this criteria, diagnostic criteria, and you have to know what is LS Coriel new one, what is the older LS Coriel criteria, what is Avaji criteria, and how Coast criteria is different from these two. Okay, that you have to
mm,
go. That is all theoretical aspect, but then you have to go through and remember it.
mm.
Okay, in that major changes happened in the EMG.
EMG, ma'am,
So you should tell
fasciculation is
that yes, so fibrillations were
fasciculation.
included.
Yes,
Positive sharp waves are also included.
mm.
Okay, in the active denervation. That is very very important actually.
Yes,
That
yes.
that was changed from the LS Corel criteria.
Huh.
Okay.
Yes, ma'am.
Mm. So this is definite or what ALS this is?
Ma'am, definite because three region EMG showed
But are
fibs.
you very sure of UMN? Because it is three regions UMN plus LMN. Huh? It's not just
Uh,
LMN.
no, no, then not definite probabilities there, ma'am. Because no three sites were there. But in EMG, there were fibs as well as fasciculations and neurogenic changes. But clinically, we cannot say definite.
Mm.
Hello?
Hello.
Yes, ma'am.
So UMN plus LMN in three regions. Bulbar, if there was bulbar involvement, we would have said that it, I mean, definite. Okay, so at
Yes, ma'am.
present, if we consider upper limb, because your ankle is absent, but in upper limb, wasted segment has good reflexes. Okay,
Yes,
so
ma'am.
we can say that at least two segments have UMN plus LMN. Lower limb का क्या है UMN?
नहीं है मैम, यूएमएन
What about
लोग
the
हैं.
thigh wasting and knee reflex? Knee reflex is coming, right?
हाँ, it is coming, but it is
हाँ
2 plus.
हाँ. So, I mean, compared to the cervical, thoracic, lumbar segments, ankle is absent, but the lumbar segment maybe एक reflex is coming, that is in the knee. So, I would
Hmm.
say that it could be, I mean, if there we have to observe the patient further. But because there are preserved reflexes in the wasted segment, I will consider those preserved reflexes as UMN.
Hmm.
Okay, because
Yes,
in
ma'am.
the wasted segments with fasciculations, LMN finding, I would expect the reflexes to go. Okay, if still
Hmm.
they are there with so much of wasting, if finger flexion is also coming, I would
Hmm.
consider this as a at least two regions there are definitely UMN plus LMN.
Hmm.
Okay, that is legs and arms. Okay,
Hmm.
and even in the abdomen, you said abdominal reflexes are preserved, but there are fasciculations also.
Yes, ma'am.
Actually, there are three regions there UMN plus LMN.
Hmm.
Okay, so we can say that this could be a definite ALS, clinically definite ALS, just on the basis of preserved UMN findings.
Yes, ma'am.
Okay, preserved reflexes. What will you do in this case? See, guidelines are different. Clinical practice could be different. So there are many thoughts that in these cases where there is predominantly LMN, one can consider giving immune therapies, but you have to
Hmm.
prove it. Okay, that there is an involvement of roots. Hmm? So you have to, for ALS case, you should remember what are the variants of ALS. Okay, what are the secondary causes of ALS. Hmm?
Hmm.
Then you have to remember the L Escorial, Avaji criteria, and the Gold Coast criteria.
Yes, ma'am.
Okay. And in your examination, major finding was that LMN cases you mention the power of each muscle.
Yes, ma'am.
Okay. I think this is enough.
Yes, ma'am. Thank you.
Okay. Okay, sir.
Yeah, anybody have any question they can ask? Okay, if there are no further
Okay.
questions, can
Yeah.
conclude the session.
Yes,
Thank
sir.
you,
Yes, sir.
Malia madam
Yeah.
and
Okay.
Dr. Hinal for
Yes.
this.
Thank you, ma'am.
Thank you,
Thank you,
sir.
sir.
Thank you. Yeah. Bye.